Behind locked doors, how long-term psychiatric institutions can breed dangerous affiliations. Psychiatric hospitals, state institutions, and long-term forensic facilities are often imagined as places of healing, sanctuaries where the mentally ill receive care, rehabilitation, and a path toward reintegration. But beneath this ideal lies a more complex, often unsettling reality. These institutions can also serve as crucibles where the most dangerous minds, psychopaths, sociopaths, the criminally insane, and individuals with paraphilic disorders, interact, influence, and sometimes evolve together. In environments where nearly 70% of residents have prior incarceration histories, the line between treatment and containment blurs. The question arises, do individuals leave these institutions more socially entangled with antisocial peers than when they entered? Long-term psychiatric facilities, especially forensic hospitals, are not monolithic. They house a spectrum of individuals, those with severe mental illness, individuals found not guilty by reason of insanity, NGRI, people with comorbid antisocial traits or psychopathy, those with paraphilic disorders or compulsive violent ideation, and malingerers seeking refuge from prison or street life. These populations don't just coexist, they interact, observe, and influence one another. The result is a social ecosystem that mirrors prison hierarchies, complete with dominant structures, manipulation, and survival alliances. In such environments, criminal cognition can be contagious. Through proximity and repetition, antisocial behaviors are normalized, paraphilic ideation may be reinforced, and psychopathic traits are valorized. Charm, dominance, and emotional detachment can elevate one's status in the ward hierarchy. Studies in forensic psychiatry have shown that peer influence in institutional settings can reinforce deviant behavior, especially when treatment is custodial rather than rehabilitative. Beyond peer influence, the very structure of long-term hospitalization can erode identity. Loss of autonomy fosters dependency and learned helplessness. Rigid routines and surveillance mimic carceral control, reinforcing criminal self-concepts. Stigma and labeling, psychotic, dangerous, untreatable, can become internalized, shaping how individuals see themselves and others. When individuals are released, they may carry not only their diagnoses, but also new affiliations, criminal strategies, and distorted worldviews forged in institutional crucibles. Complicating this dynamic is the growing trend among some law enforcement agencies and local jurisdictions to prefer psychiatric hospitalization over jail or prison. On the surface, this may appear humane, diverting mentally ill individuals from punitive systems into therapeutic ones. However, this preference can be abused. Crisis services, emergency psychiatric holds, and involuntary commitments are increasingly used as tools of containment rather than care. In some cases, individuals are funneled into psychiatric facilities not because they pose a clinical risk, but because they are inconvenient, disruptive, or politically problematic. These crisis interventions can function as soft imprisonment, spaces where criminal associations are formed, reinforced, and even strategized under the guise of treatment. The result is a shadow system of containment that mirrors the penal system while avoiding its legal scrutiny. The U.S. mental health system has become a revolving door between psychiatric hospitals and jails. With deinstitutionalization failing to provide adequate community support, many individuals cycle through emergency psychiatric holds, involuntary commitments, jail-based mental health units, and forensic hospitals. Each stop along this circuit can deepen associations with antisocial peers, especially when treatment is reactive rather than transformative. To disrupt these cycles, we must map institutional hierarchies to identify high-risk social dynamics, differentiate between primary psychopathy and trauma-induced sociopathy, design reentry protocols that sever harmful affiliations and foster prosocial identity, and integrate survivor-centered frameworks into forensic profiling and risk assessment. Long-term psychiatric hospitalization can be necessary, but it must be protective, not corrosive. Without ethical oversight, these institutions risk becoming breeding grounds for deeper pathology, not recovery. The challenge is not just to treat illness, but to interrupt cycles of harm, rewire social learning, and restore narrative sovereignty to those who pass through their locked doors.